So, good evening, everyone. Uh, Again, you are there with Neurotology and Equilibrium Society of India's webinar, that is NES webinar number 10. Today, we do have our special guest who is not only special about medical sciences. There are only a rare examples, or maybe I have not seen the other one yet in my life, who is an engineer as well as a doctor. So we present to you today J.T. Rubinstein. J. He received his BSc, Bachelor of Science, and Masters in Science degrees in engineering. At first from Brown University in 1981 and 83. Then he received an MD and PhD in bioengineering itself from University of Washington in 1987 and 88. He completed postdoctoral research training at the one MIT itself and residency in otolaryngology in 1994 at Massachusetts Eye and Ear Infirmary. He completed a neurology fellowship then at the University of Iowa in 1995. He was right at that time of neurology fellowship itself. He was assistant professor, then promoted to associate professor in the same department of otolaryngology as well as bioengineering. Then in 2003 and 4, he went to Netherlands at Boerau Professors Leiden University to get his more like to get updated to bioengineering more. And then currently he is there at Virginia Merrill Brodel Hospital, that is a hearing research center as well at University of Washington, working as a professor now, professor of both the things, otolaryngology and bioengineering. He is having a position of director as well for the hearing research center. He has been he has got a lot of positions in the past in respectable societies there in America and throughout the world, among which he was president of American Auditory Society and Association for Research in Otolaryngology. He is an esteemed member of Collegium Otorhinolaryngologicum, the American Institute of Medical and Biological Engineering, as well as a senior member of the Institute for Electrical and Electronics Engineers. He is president-elect of Collegial Society. Collegial Society is the oldest otology society in the world. And to be as a president-elect is itself the biggest laudate an ENT surgeon can ever have, else than Nobel Prize. He has published more than 130 peer-reviewed articles in both clinical as well as the basic science journals, and he has mentored 18 pre-doctoral and postdoctoral trainees, both in the basic as well as the translational research, as well as providing clinical training to a large number of ENT otolaryngology residents and fellows. He maintains a busy surgical practice at both the University of Washington Medical Center and Seattle Children's Hospital. His NIH-funded laboratory studies, especially models of signal processing and perception with cochlear implants, is terrific. And the one of the best thing, a unique one in the world, is collaboration in the development of the vestibular implant. So I think we all wanted to listen to his insight, his attempts, his research methodology about vestibular implants, and how far he has gone, and he can enlighten us with the future aspects of vestibular rehabilitation as well, I suppose. And he has got a lot of other recent advances which I think he is gonna speak today and enlighten us. All up to you, Jay. All the questions will be taken in the last. People can WhatsApp me all their questions. Please avoid writing in the chat box because it disturbs again and again popping in on the screen. And I'll be asking all questions. Don't worry, Jay is all there. It is his holiday today, so you can take as many questions as you want. Okay, all up to you, Jay. So you can share your screen now, or Dr. Prahlad can do that.
Yeah, he has to share his screen. Yeah.
Okay,
Yeah.
share your screen, Jay.
Let's see, there we go. Is that up okay?
Perfect.
Yeah.
Great to go.
Thank you.
Yeah.
Well, thank you for the kind introduction. And it's a pleasure to be speaking with people as widely dispersed as you all are. I think last I checked, there were 100 people signed on to this. And it's really nice, as I was saying earlier, to see a world outside of my clinic, my operating room, and my home. Yeah, just an update of where COVID is in Seattle. We had shut down all of our elective surgeries for about 2 months. We started them back up again about 6 weeks ago, and currently I'm running a full surgical schedule, but we've reduced clinic volumes to about 60% of normal, so that we never have large groups of people in our waiting areas. It's been a challenge for us, as I'm sure it has been everywhere else. In addition, pertinent to this presentation, all of our human subject research is shut down. We cannot do any human subject research that involves the person being present in person. And so obviously we're not currently making advances in the area of the presentation I'm giving you today. But hopefully we'll be doing that again soon. We're in the very early era of vestibular implantation in humans. And so I find it helpful to look back to the early era of cochlear implantation in humans. And here is a news release from Stanford Medical Center in June 1965. This is the first person, Anthony Vieira, to receive a multi-channel cochlear implant. The surgery was done by Dr. Blair Simmons, and the testing, as you can see in the header below, was being done by Dr. Epley, or the late Dr. Epley, when he was a junior resident. So this really does stretch back. So first adult with a multi-channel cochlear implant. You have to leap forward over 20 years to find the first child with a multi-channel cochlear implant. And I'm particularly fond of this slide. This is Timmy Brandow, who was the first child in the United States to receive a multi-channel cochlear implant, sitting on the lap of my mentor, Dr. Gantz, in 1987. And by 2016, they had to switch roles. Timmy is he goes by Tim now, not Timmy. Tim is a biomedical engineer who trained at the University of Iowa. It helps to kind of look back and get perspective as we think of where vestibular implants may hopefully go in the future. Hopefully they'll be as much of a success as the cochlear implant has been. But we still have a long way to go to make it that degree of success. There are a number of vestibular disorders that are potentially treatable with a vestibular prosthesis. And our understanding of what conditions are treatable is still evolving. But when people first thought about doing this, the index condition that they were considering was the patient who has bilateral vestibular loss, very much like someone who has bilateral profound sensory neural hearing loss. And the idea is that the device would have sensors, and those sensors would be accelerometers that modulated the stimuli delivered to the vestibular nerve. But there are other potential applications of a vestibular implant. One of them is poorly compensated unilateral vestibular loss. So as you all know, unilateral vestibular loss is extremely common, and in the vast majority of cases, within weeks or months, the individual compensates for it, and does not have significant balance issues. However, in a small percentage of those people, they continue to have ongoing uncompensated vestibular symptoms that are not that different from what someone with bilateral vestibular loss has. This condition may or may not require a modulation of stimuli to the vestibular nerve. There are reasons to think that just applying a steady pulse train to the vestibular nerve on the weak side might improve imbalance in these individuals. Either of these two conditions may or may not be associated with hearing loss that's amenable to a cochlear implant. One of the research problems we face is that most of these people are not deaf in the ear that we're trying to treat. And so the challenge is to stimulate the vestibular system effectively, but without losing any residual hearing that the patient may have in that ear. Vestibular implants have been placed in a small number of human subjects around the world. The Johns Hopkins group, led by Charlie Della Santina, has implanted at least 8 patients who have, I believe, mostly have gentamicin ototoxicity. The collaborative group between Maastricht and Geneva has implanted 8 patients who are actually cochlear implant candidates, but who have laboratory evidence of bilateral vestibular loss. The group in Las Palmas, led by Professor Angel Ramos, has implanted at least 3 people with a different device than the rest of us have worked on. The Las Palmas group is attempting to stimulate the otolith organs, and they've shown some early success in reducing imbalance with steady, unmodulated stimulus delivered to the vestibule. Now, the vestibule is an anatomically complicated site, so whether in fact that device is stimulating the otolith organs or directly stimulating the vestibular nerve, which begins immediately adjacent to the vestibule, is currently unknown. But regardless of exactly what's getting stimulated, the early results show some significant promise at improving imbalance. And I think we're likely to be seeing a multi-center clinical trial of that technology in the near future. At the University of Washington, we began by implanting 4 patients with uncontrolled Meniere's disease. These are patients who had hearing loss that was sufficiently severe that they were candidates for labyrinthectomy. And instead of doing a labyrinthectomy, we performed a vestibular implant. We then subsequently implanted 3 patients with a combined cochlear and vestibular implant. And those are the patients I'm going to talk about today, after I briefly review the 4 Meniere's patients who we began implanting 10 years ago now and have published all of the results from them. So this was our first generation vestibular neurostimulator. As you all recognize, it's based on the nucleus freedom cochlear implant with 3 electrode arrays. And there's 3 electrodes on each of the arrays. And the purpose of these arrays is to go into the semicircular canals adjacent to the ampulla. And the idea behind it is to be minimally invasive, like a hybrid or EAS cochlear implant, to try not to destroy hearing or any residual vestibular function. And in this cartoon, you can see how the device was sized so that it could potentially fit within the paralymphatic space of the semicircular canal, hopefully not compressing or puncturing the membranous semicircular canal. This device did not have a cochlear array on it, and our goal was to implant these patients, hopefully preserve their hearing, and then have a device that would allow us to modulate their vestibular nerve when they were having Meniere's attacks. Unfortunately, we never really got to study that because the effect of the surgery in all 4 patients was to destroy the residual hearing, and also the residual vestibular function. But we did get to study them extensively and learn a lot about electrical stimulation of the vestibular nerve in humans. We also developed what we call the bone-anchored rotational prosthesis. The idea behind this was that it would be a 3 degree of freedom accelerometer that is attached to an osseointegrated implant on the skull in order to rigidly fix it there. And it encodes head velocity on 3 audio frequencies. Those 3 audio frequencies are then delivered to a cochlear implant speech processor. And we reprogrammed that speech processor to extract those 3 audio frequencies and encode the head velocity that was extracted from that onto the electrode arrays in the inner ear. So our first feasibility study with the Food and Drug Administration, we were allowed to do up to 10 human subjects at UW Medical Center. They had to have American Academy of Otolaryngology defined definite Meniere's disease. They had to have failed medical management and be a candidate for routine surgical intervention. And the idea was that if the device failed to control the Meniere's disease, we would then perform a routine endolymphatic shunt or a labyrinthectomy and remove the device. So we implanted 4 people under that category between 2010 and 2012, and all 4 of them lost their hearing and their ipsilateral vestibular function postoperatively. And we described those 4 patients in detail in the Journal of Neurophysiology in 2015. We monitored their electrically evoked vestibulo-ocular reflex, their vestibular electrically evoked compound action potentials, as well as electrically evoked sway measures on a platform, and their electrically evoked percepts of motion over a 1 to 5 year period. One of our subjects died of prostate cancer about a year after implantation, and so we only have data up to 1 year on him. But the other subjects we followed for up to 5 years. This is a surgical image of our first subject. This is 10 years ago now. And you can see on the left here, I've blue lined the posterior semicircular canal, and with an angled straight pick, I've made a fenestration in the endosteum of the posterior semicircular canal. And this shows the electrode array going into the posterior semicircular canal. And here you can see the electrode array going into the lateral semicircular canal, and this electrode array is going into the superior semicircular canal. From this projection, it looks like the superior canal electrode is perpendicular to the canal, but it's not. That's just because of the angle of this photograph. The tip of the electrode is pointing towards the ampulla of the superior semicircular canal. And this is just a small piece of temporalis fascia that I'm using or trying to use to both secure the electrode and seal the fenestration. And these electrodes are not very securely fixed into the semicircular canals. So it was very important to secure the electrode cable using this stitch, which is a trick I learned many, many years ago, back when the Nucleus 22 was the cochlear implant available to us. And that device also was not very secure in the cochlea. And when I was a fellow, Dr. Gantz taught me that you can prevent the electrode from coming out of the cochlea by securing it to the mastoid cortex, which decreases the amount of mechanical play that the whole device has. Here is that trifurcation that you saw in my image of the device, and the receiver stimulator is back here, and I have not placed the remote ground electrode yet. Intraoperatively, we record compound action potentials from the vestibular nerve to demonstrate that our electrodes are in the right place and that they're close enough to the ampulla to electrically activate it. We performed experiments in 10 rhesus monkeys before we implanted any human subjects, and we demonstrated that compound action potentials require your electrode to be very close to the ampulla. We initially started placing our electrodes 180 degrees from the ampulla in order to try to minimize trauma to the inner ear. But we found that we could not get ECAPs if we implanted that far from the ampulla. And we demonstrated that if you keep moving the electrode closer and closer to the ampulla, your ECAPs get bigger and bigger. Although we haven't demonstrated it, we presume that if you puncture the ampulla with your electrode array, your ECAPs may actually get smaller. But we didn't try to do that. We placed the electrodes far enough from the ampulla that based on the anatomy, we believe the electrode is immediately adjacent to it, and then confirm that we get good responses electrically. And this is a response from the lateral canal and from the superior canal in our first subject. This is what the device looks like on a post-operative CT scan. And if we look here, you can see the electrode near the posterior canal ampulla, which is right here. This is, excuse me, this is our first subject. And so this was the first human I had implanted with this device after implanting 10 rhesus monkeys. And you can see that my posterior canal electrode is not quite as close to the ampulla as I'd like it to be. In contrast, particularly, this is the superior canal electrode, and you can see it's spot on right next to the ampulla. And here's the lateral canal electrode, which is also spot on right next to the ampulla. But to put the posterior canal electrode into the next to the ampulla, you actually have to drill underneath the facial nerve. The posterior canal extends medial to the facial nerve, and you have to actually follow that canal quite a bit anteriorly under the facial nerve in order to get it closer. And in later patients, I was able to do that, but I chickened out in this first subject and didn't get it quite close enough. And we saw the effects of that in the relatively less responsiveness that the posterior canal electrode gave us. In the post-operative period, and in this particular gentleman for 5 years, we studied a number of things. We looked at electrically evoked eye movements, and that's what we're doing here. And we looked at electrically evoked postural sway, and that's what we're doing right here. And you can see he's got his VNG goggles on, and he's also got his cochlear ear hook on at the same time. This is my colleague, Dr. Jim Phillips. Jim is a vestibular physiologist who studies the vestibular system in rhesus monkeys and also runs our clinical vestibular laboratories. And the most important piece of equipment on our first subject is the t-shirt that his wife made for him, which you can't quite read, but since we had done 10 monkeys before him, his t-shirt reads Monkey Boy 11. So after a year of evaluating these individuals, we found a number of things. Rotational perception, postural sway, and nystagmus are not uniformly linked. So when we activated these devices, some of them would get robust rotational percepts, but no eye movements. Others would get very strong eye movements. And this differed across subjects and also across semicircular canals within a subject. Because of the loss of hearing, we determined that this was unlikely to be a useful intervention for Meniere's disease. But the results we obtained with activation of the vestibular nerve demonstrated promise for treating other conditions. However, we found an overall decline in electrically evoked eye movements over time. One of the important characteristics of the success of cochlear implants is that we put cochlear implants in people, and decades later, assuming the device hasn't failed or they haven't had an infection, the device still works very much like it did early on. You see an improvement in speech perception over the first year, and then after that, things are stable in many cases for decades. But we did not see that. We saw a decline in electrically evoked eye movements over time. We also saw something interesting for those who are interested in Meniere's disease. This paper is actually in the July Otology and Neurotology. It just came out a couple of days ago, even though the data is quite a few years old now. In subject number 1, this is the electrically evoked VOR obtained with stimulation of the lateral canal. And the y-axis is the slow phase eye velocity, and the x-axis is the stimulation current. And the different colors is the week after surgery that the stimulation took place. And it varies between 2 weeks after surgery up to 255 weeks after surgery. So nearly 5 years. And if we choose a specific stimulus intensity, let's say 300 microamps, and look at and plot what the eye velocity is over time, you can see that initially we're getting 8 degrees per second, but then the response decreases down to 2 degrees per second, but then it increases to 4 degrees per second. It decreases after that almost to 0, and then it increases to about 5 degrees per second. And the error bars demonstrate that this is a statistically significant fluctuation in the electrically evoked eye movement over a 5-year period. Now, I was always taught when I was a resident that Meniere's disease is a peripheral process, and all of the fluctuations that we see are due to fluctuations in the vestibular and cochlear end organ. But looking at this data, as well as some other things, as well as fluctuating hearing that we've seen in people with cochlear implants, really makes me wonder, is there not a component of afferent excitability fluctuation that we're demonstrating here with the vestibular implant? That remains to be proven, but I think it's a fascinating observation on the physiology of Meniere's disease. Based on the results in those subjects, we developed a new version of the device to try to prevent the loss of effectiveness over time that we saw. And so we decreased the number of electrodes from 3 to 2, and we doubled the surface area of those electrodes to decrease their impedance. In our first generation device, the impedances were extremely high, in most cases over 20 kiloohms. And the cochlear device has a very difficult time driving any reasonable current level into such a high impedance. So by doubling the surface area, we thought we would decrease the impedance, and that proved to be true. And by lengthening the electrode array, we had hoped to better stabilize the electrode array within the semicircular canals. Because as I told you earlier in our monkey studies, any movement of the array away from the ampulla would lead to a loss of excitability. We also increased our subject pool from just labyrinthectomy candidates to include anybody who had symptomatic vestibular loss with speech discrimination of less than 50% in the ear, in at least one of the ears with vestibular loss. It could be unilateral or bilateral vestibular loss, but they had to be severely symptomatic, and they had to have less than 50% speech discrimination in one of the ears with vestibular loss. And so this device also has 3 semicircular canal arrays, but it also has a hybrid L cochlear implant array to place within the cochlea to restore the speech discrimination that we assumed we might lose with placement of the vestibular electrodes. This was our first subject who had actually had sudden hearing loss years earlier and had a Baha placed for single-sided deafness about 10 years beforehand. And this just shows that many people worry that you couldn't put an abutment on the same side as the receiver stimulator of an implant. But if you reorient where the implant goes, there's plenty of room to stay away from a skin penetration. So I'm not at all concerned about the possibility of placing an abutment in the vicinity of a receiver stimulator in order to securely anchor the velocity sensor. So this was our first human subject with the new device. She was a 57-year-old woman with bilateral vestibular loss and unilateral deafness in the left ear. Her history was that she had sudden hearing loss with acute vertigo 10 years earlier. Her vertigo resolved, but after the vertigo was gone, she was left with oscillopsia. And on testing, had bilateral loss. We assume she had a pre-existing vestibular loss in the contralateral ear, and she had sudden hearing and vestibular loss in her left ear, and that left her with bilateral vestibular loss and unilateral deafness. So 10 years after her BAHA, which was placed at the time that this all occurred, she was profoundly deaf on the left, normal hearing on the right, and profound vestibular loss bilaterally. And this shows her postoperative electrode placement. This is the posterior canal electrode. And since this is now my 5th human subject, you can see my electrodes a lot closer to the ampulla this time. This shows her lateral canal electrode. This shows her superior canal electrode. And this shows her cochlear implant electrode. So that's what the new device looks like on a postoperative CT. Now, in the operating room, we were concerned because we could not get any ECAPs from any of her canals. We were concerned that she would not get any vestibular stimulation. And sure enough, postoperatively in the laboratory, she had absolutely no vestibular percept or eye movements at any time over the course of a year. In later months, she did have unusual percepts and some very abnormal eye movements, but nothing that looked like organized nystagmus when we stimulated the vestibular arrays. However, her cochlear implant worked fine, and she functions as a single-sided deaf cochlear implant user. This was obviously a very depressing case to do our first new device surgery in, but we pushed on to subject number 2, subject number 2 is a 75-year-old woman with bilateral Meniere's disease for 50 years that was currently inactive. But she had severe unsteadiness and oscillopsia with severe to profound sensory neural hearing loss, left worse than right, and bilateral vestibular loss. She met cochlear implant criteria bilaterally, but she really wanted a device that could potentially treat her vestibular loss too, so she elected to place the combined vestibular and cochlear device on her left, and we did that in July of 2018. We obtained beautiful vestibular and cochlear recaps intraoperatively, and she's acquired speech recognition with her bimodal cochlear implant as expected. She wears a hearing aid on the right side. But she also notes that just the improved hearing has improved her balance. And this is a phenomenon that the team in Toronto has described. Sharon Cushing has shown in kids with Usher's syndrome that bilateral implantation seems to improve balance relative to not having bilateral hearing, which is a fascinating phenomenon in and of itself. Here's the images of her electrode. We have a rare opportunity to see the cochlear electrode and the superior canal electrode on the same cut. These are what her responses look like. And this is a very busy slide, and this was published in Otology and Neurotology a few months ago. And what we have on the left column is stimulating the lateral semicircular canal, and we're measuring the horizontal eye movements and the vertical eye movements. Again, stimulating the superior canal or the anterior canal to a vestibular physiologist. Surgeons and physiologists label the superior semicircular canal differently. The physiologists call it the anterior canal. Stimulating the superior canal, you see there's a big vertical component of the eye movements. Again, x-axis is current, y-axis is eye velocity. And then stimulating the posterior canal produces an unexpectedly large horizontal component and a smaller vertical component. So we get a puzzling large horizontal component from the posterior canal, but the lateral and superior canals produce very robust eye movements in the appropriate direction. And you can see that the first time we activated her, we were able to get eye velocities over 100 degrees per second. This is with our second generation device. The biggest we ever saw with our first generation device was 30 degrees per second. And that's because of the impedance issues that I described to you earlier. So this second generation device is far more effective than the first generation device, and the results lasted. So by a year, she still had extremely robust electrically evoked eye movements. But in addition, we were able to demonstrate in a manner that Charlie Della Santina at Hopkins has also demonstrated, that if you put a velocity sensor on the patient and connect that to the device and put them in a rotary chair, that you can actually restore VOR gain, rotational VOR gain. And in her case, we were actually able to restore her VOR gain to normal at least one frequency. So this is extremely promising in terms of being able to provide long-term improvement in the vestibulo-ocular reflex. Our third human subject was a 70-year-old man with bilateral Meniere's disease. He had had a left vestibular nerve section at another hospital that was complicated by profound deafness. And he underwent an advanced bionics cochlear implant in his left ear at that center. And he was a very successful implant user. So even though he went deaf after vestibular nerve surgery, obviously his cochlear nerve was still working fine. He had severe to profound deafness in his right ear also, and bilateral vestibular loss. And in December of 2018, so about a year and a half ago, underwent a combined vestibular and cochlear device in that ear. And we obtained beautiful vestibular and cochlear ECAPs intraoperatively. He did have some residual hearing in that ear, which was once again lost. That seems to be a rule in these people with Meniere's disease. We have not yet implanted someone with residual hearing who doesn't have Meniere's disease. The first of the three subjects I've been telling you about did not have Meniere's disease. She had sudden hearing loss, but the ear we implanted was profoundly deaf already. So we don't know whether we would have preserved residual hearing or not. This individual is acquired speech recognition with his bilateral cochlear implants. He has our cochlear manufactured vestibular cochlear device in the right ear and an advanced bionics cochlear implant in the left ear. This slide is now old. He has robust vestibular responses with stimulation out beyond a year. So these are his responses. And this is stimulating the lateral semicircular canal, and we get very, very large horizontal nystagmus as expected. We get some vertical nystagmus as well. It's about half the amplitude of the horizontal nystagmus. With stimulating the superior semicircular canal, he gets a larger than expected horizontal component and a robust but vertical component. And stimulating the posterior canal, we are again seeing this unusual horizontal component, but he gets a large vertical component. That's what you would expect based on the canal plane. And you can see this goes down to 80 degrees per second. So clearly this device is producing much more robust eye movements than our first generation device, and it's producing it for at least a year. So the device design change has accomplished the goal of creating larger responses that last better over time. But one of the things that we've also found is that since we have a cochlear implant and a vestibular implant, the two appear to interact with one another. When we stimulate the vestibular implant alone, none of the patients report hearing anything. And if we stimulate the cochlear implant, we don't get any eye movements or vestibular percepts. However, if we stimulate the two together, The vestibular electrodes affect the loudness of a cochlear percept, and the cochlear stimulation affects the eye velocity of the vestibular response. It's a little complicated to explain based on the single slide. It's not in press. It came out in Audiology and Neurotology several months ago. It's a very puzzling phenomenon. We don't think it will detract from a vestibular implant in any way, but it is something that we'll need to keep aware of as we have more patients wearing combined vestibular and cochlear devices. These are subjects number 2 and 3. Wearing their, in their case, we do not have an abutment on which to attach the sensor, and we're not yet ready to give them a chronic device to take home. But here they are walking around the laboratory. This has a power supply and electronics for the rotational sensor, which is attached to the strap on their head. We can do things like look at the effect of the device on their gait and their stability when they're out wandering around and not just on a platform or a rotary chair. So in subject number 1, who did not have Meniere's disease, there was a clear dichotomy between the electrical sensitivity of cochlear and vestibular afferents. And so the etiology of the vestibular loss may be much more important than etiology with cochlear implants. You know, as you all know, with the exception of cochlear nerve deficiency, or when you implant people who have acoustic neuromas, with the exceptions of cases like that, it is very unusual for a cochlear implant patient to not get significant benefit, and not even, and even rarer to not stimulate at all. But in subject number 1, the vestibular nerve didn't stimulate at all, even though the cochlear nerve stimulated fine. And we think that may be related to the etiology. In 2 other subjects, our 2nd generation device appears to be able to provide much higher intensity vestibular activation than its predecessor. In subject number 2, we were able to restore sinusoidal horizontal VOR gain, which improved, subjectively improved her imbalance. And we have great vestibular responses after 12 months in both subjects number 2 and subjects number 3. I'll stop there and acknowledge my contribution to co-authors. I'll be happy to answer any questions that have arise. And I've got some other slides if those questions may be better addressed with those other slides.
Thank you, Jay. It was a nice lecture and insight about vestibular implants. So, when did you do your first implant, vestibular implant, Jay?
The first implant was done in 2010.
2010. Okay.
We did our 4 first generation implants between 2010 and 2012. It then took several years to get the new device designed and manufactured and approved by the FDA for experimental use. And then we also needed to get funding from the National Institutes of Health to implant it. And we began doing our 2nd generation device in 2008.
Okay. Can you please unshare your screen, because we want to see you. We guys can come together on the screen. You need to unshare it. Okay. So we are there. Prahlad sir, can you unmute Amit Goyal sir also? Dr. Amit Goyal. And unmute yourself as well, Prahlad sir.
Okay. Yeah, I've unmuted. Yeah.
And Dr. Amit Goyal. Okay. Amit boss, you are there. So a few questions I do have right now for Jay. Dr. Rajat Jain, he has asked, like, what should be the minimal hearing status for vestibular implants? as you know, it can cause permanent hearing loss in patients. So minimum hearing status, the criteria for your select you for you to select a few patients who do have some residual hearing maybe or don't have hearing. So which, how do you divide that?
Yeah, so that's still to be determined because most of the people we've implanted have Meniere's disease and they've all lost their residual hearing. Um, the Baltimore group, the Hopkins group, has implanted people with lots of residual hearing. In fact, several of their subjects have near normal hearing, uh, and they've had pretty severe hearing losses in at least two of them um, early on. And so clearly, none of these current devices are safe to hearing. And so, to my mind, I would not do this research on anybody who had more hearing than a cochlear implant could provide. So we chose for our research in our second generation device to set the criteria as 50% discrimination, because we expect on average a cochlear implant to provide a little bit more than that.
Yes.
Our average cochlear implant outcomes are about 63%
Okay.
monosyllabic word scores. So that's the criteria that we use. Other research teams have more aggressively gone after people with more residual hearing. I personally would not be comfortable doing that.
Okay. And Rajat again asked something more like, did any of your vestibular implant stimulate the facial nerve ever in any patient? Does it do that? Facial nerve stimulation or facial nerve paralysis somehow?
Good question. So in monkeys, we see that all the time. So
Okay.
the something about the location of the facial nerve relative to the ampullae in rhesus monkeys makes facial nerve activation very, very common. We have not seen that in any of our human subjects. In our first subject, it was actually quite interesting. The threshold for his posterior semicircular canal was extremely high. And when we stimulated that electrode at very high levels, it caused his ear to twitch. It activated the postauricular nerve to the postauricular muscle.
Muscles.
And in subject number 2, we saw the same thing intraoperatively. You could see the muscle contract while we were recording ECAPs from the posterior semicircular canal.
Oh, quite interesting.
And if you think about it, the postauricular nerve branches off the facial nerve immediately adjacent to the ampulla of the posterior semicircular canal.
You mentioned that. Yeah.
Something about the bifurcation makes it particularly sensitive. But other than the postauricular muscle, we've not seen any facial nerve activation in any of them.
Okay. So I think it is more there with a few cases in cochlear implantation. We do have stimulation of the facial nerve sometimes, especially in some states where it is like laterally placed implant, or maybe you require more threshold.
Otosclerosis also
Yeah,
sometimes.
otosclerosis, yes. Sometimes even in even cases of labyrinthitis ossificans, which we have put in an implant, may sometimes get some stimulation of the facial nerve. I think that
So
was
in my
a big
practice,
thing.
that's most common in otosclerosis.
Yeah.
So,
Can I ask a question?
There's one more question, Ahmed, Dr. Ramesh Rohiwal. He is a senior ENT surgeon who is totally into the vestibular system. He is a vestibular consultant. So he asked, like, you are putting vestibular implants in semicircular canals and stimulating that in cases of hypofunction. What about the stimulation of the ventricle and saccule?
I'm sorry, I missed the
Yeah.
second.
So you are by inserting the vestibular implant in semicircular canals, you are just stimulating the semicircular canals. But what about stimulation of the utricle and saccule?
Yeah. So we would like with the semicircular canal electrodes to only stimulate the semicircular canals. But we have demonstrated that at higher stimulus levels, people perceive not just rotation, but they also perceive a tilt. We actually saw this in our first subject. And as we increased the stimulus, he would say, I'm rotating horizontally. But as we went up to higher levels, he described himself tilting like a gyroscope. He was both rotating and tilting. We interpret that to mean that we're getting some otolithic activation from the semicircular canal electrode. As I mentioned at the beginning, the Las Palmas team has actually placed electrodes in the vestibule for the purpose of stimulating the otolith organs. I'm not certain that they're actually stimulating the otolith organs. My belief is they're stimulating the entire vestibular nerve. Because if you look at the anatomy of the internal auditory canal, basically the fundus of the canal is a very thin, bony layer separated from the vestibule. So an electrode in the vestibule may very well be activating the vestibular nerve. The only data we have about what electrical stimulation does to the otolith organs comes from experiments that the Johns Hopkins team has done on chinchillas. And the results are very mixed, as you might expect, because the otolith organs have a very different physiologic arrangement. They have nerve fibers very close to each other that code different directions, opposite directions of motion. In each of the semicircular canals, only one direction of motion is encoded. But in the otoliths, each otolith encodes two directions. So it's unclear what's going to happen over time with stimulation of that organ. But I think we'll probably find out more as we see more data from the Las Palmas group in Spain.
So you could you could even develop one more added electrode going somewhere in oval window and stimulating the saccule directly.
You certainly could. The closer part of why I've avoided vestibule, like electrodes in the vestibule, is because I'm really interested in trying to preserve residual hearing. The closer you get to the cochlea, the more likely you are to damage it. Now, I place cochlear implants and preserve residual hearing regularly, but those are not in people who have diseases like Meniere's disease, for example.
Yes.
And so, as I said, it remains to be seen what how likely is hearing preservation in any of these sorts of procedures. But my own suspicion is if we're implanting the vestibule, we're more likely to get hearing loss than implanting the semicircular canals. But clearly, to restore normal vestibular function, you would want to have the opportunity to activate all aspects of the vestibular system.
Yes. So we do have our secretary of the Neurology Society of India, Dr. Amit Kesri. He wanted to ask something. Then I do have a couple of more questions with our audience.
So my question is that we have a subset of patients of Meniere's where there is a bilateral profound hearing loss. The disease has caused some hearing loss, but due to the repeated gentamicin injection, intratympanic gentamicin injection, they develop hearing loss. And we did cochlear implant for 2 of these patients. They were very happy with the hearing, but they still have some balance issue. So have you done any implant where after the Meniere's disease, the bilateral hearing is gone and the patient has bilateral vestibular failure, your second generation implant? I mean, the hearing is already gone. So if you can put in the second generation CI and vestibular implant together, will that patient will benefit more?
I think so, yes. Subjects 2 and 3 that I discussed today both had bilateral Meniere's disease. In the case of subject number 2, it was burned out on both sides. She was no longer having acute attacks. She had never received gentamicin injections, but she developed bilateral vestibular loss just from her underlying Meniere's disease, and she was profoundly deaf bilaterally. She was able to use a hearing aid in one of her ears, so we implanted the non-aidable ear, and she just even from the hearing noted improvement in her balance. but she was the one where we were able to restore normal VOR gain. And when we were doing that, she had the biggest smile on her face that I've ever seen,
Exactly.
because her baseline feeling of being off balance was much, much better. So yeah, those people who've had bilateral Meniere's disease, whether or not they've received intratympanic gentamicin, if they go deaf and they have vestibular loss, are the perfect candidates for a combined vestibular cochlear implant.
So I think you have already answered an absolute indication for vestibular implants, which was asked by Dr. Pratik Purwar. That what is an absolute indication for vestibular implant is like bilateral Meniere's disease, in which even the hearing is gone, and those are the best candidates. I think what you have narrated, we can conclude that. Or any other indications you do have for vestibular implants?
So our first subject had sudden deafness and vestibular loss, and had no vestibular response. But she had her disease 10 years ago, and I would love to try to do the same procedure on someone who had sudden hearing and vestibular loss 6 months ago. And the reason, I'm going to actually share my screen again, because that's one of the interesting slides that I had at the end. Share screen, and
Can you share that?
yep.
Last, sir?
Yeah, he can share that. Yeah.
You can share, yeah. Okay, you skipped this slide.
I did.
Yeah.
So this is actually from a guinea pig, not a human. But you can see this is the internal canal right here, and this is the vestibular ganglion. And if you think about where our electrodes are in the ampullae of the canals, they're quite far. So here's an ampulla right here, and you can see how far it is from the vestibular ganglion. When we do cochlear implants, we put our electrodes in the cochlea. The spiral ganglion is immediately adjacent to our electrode. And it's been known since the early days of cochlear implants that when you have prolonged deafness, you lose the afferent process of your spiral ganglion cells. And in a cochlear implant, that can lead to loss of frequency selectivity, but you can still activate the nerve because the cell body and the axon are still very close to your electrode. But if the same thing happens in the vestibular system, where over time the afferent limb of the ganglion cell dies and dies back to the cell body, which is here, our electrodes are very, very far from that. And to my mind, that's what explains why our first subject, who was 10 years out from sudden hearing and vestibular loss, could hear with her cochlear implant very well, but could not get any vestibular activation. We're trying to stimulate a ganglion that's very far away. Now, if you put an electrode into the vestibule, that's very close to the vestibular ganglion, and that's what leads to my comments about the Las Palmas group. I think if you put an electrode here, you're more likely directly activating the vestibular ganglion and the vestibular nerves in the internal auditory canal because you're so close to them. I'll stop screen sharing.
Great.
Can I ask something?
Yeah, sure. Dr. Amit Goel wants to ask a question. He is past president of neurology, and he is professor with All Indian Institute of Medical Sciences, Jodhpur. Dr. Amit Goel.
Yeah, thanks, Pawan. So, Jay, it was a fantastic presentation, and it's a great, I must say, path-breaking development you have gone through. I'll just like to ask one question. You have done implants, you have assessed them, electrophysiological and all, but most of your patients are quite old patients who already have some vestibular, not only vestibular problems, cognitive problems also, and hearing problems also. Most of the times, if you regain hearing, most of their cognitive problem might be taken care by CI as such. And most of the diseases, they are chronic diseases where adaptation also chips in. So what I want to ask you that what do you think that actual clinical benefit from a vestibular implant in terms of cognition and in terms of their stability as the patient feels? So vis-a-vis, because it's certainly it's going to be a costly affair. So what actual clinical benefit you have seen as of till now in these chronically vestibular where chronic problem is there?
Okay, good. Those are all excellent questions. Regarding the cognitive impacts, we don't really know the answer to that question. We're actually in our clinic, we're now doing the Montreal cognitive assessment in every person who gets vestibular testing. So we can begin to see, does vestibular loss correlate with cognitive deficits in the same way that hearing loss does? But yes, most of our subjects are indeed older. Our youngest subject is 50, and that was with our first generation device. But the vast majority of them are in their 60s and 70s. We do not chronically stimulate the vestibular nerve in our subjects. They have a chronically implanted device, but we do not have FDA approved for a stimulator that we can send them home with that's chronically stimulating their nerve. In our second generation device, the only clinical benefit they're getting is the clinical benefit of their cochlear element.
Can you, sorry, Jay,
All of our,
can you repeat because there is some disturbance in the voice. I think Srinivas, it's your screen is blinking.
Yeah.
Can you repeat, please, Jay? I'm sorry to interrupt. Please, it was the last sentence.
Maybe more people should be muted. Can you hear me now?
Yeah. Go ahead.
So we were talking about cognitive effects, and I said that we're now doing cognitive assessments in all of our vestibular patients to look for correlations between cognitive deficits and vestibular loss. But we're not chronically stimulating our patients. The only chronic stimulation they're getting is from their cochlear device. So they wear the cochlear device at home. In the laboratory, we stimulate the vestibular device, and we do it fairly frequently to get as much data as possible. But they're not going home with a chronic vestibular sensor. We do not yet have regulatory approval from the FDA to send people home with a chronic vestibular stimulator. We can only test them in the laboratory. So we can't say what the long-term clinical benefit that any of these subjects have achieved from the vestibular component of their device. The Hopkins group has demonstrated significant clinical benefits in people who are chronically stimulated. But those benefits are still fairly subjective. They're not easily quantifiable.
Okay.
Thanks, Jay.
Dr. Mohan, NVK wanted to ask something. Mohan boss, are you there?
Yes. Yes, Pawan.
Yeah, you wanted to ask a question, boss.
Yes. Good evening, Dr. Rubinstein. Thank you very much for a wonderful talk. Really feel happy to be part of this. I was just wondering, I mean, would you consider doing vestibular implants with in patients with serviceable hearing, or would you consider it only when there is poor hearing scores?
Yeah, so with our current knowledge, I personally would not do it in anybody with serviceable hearing.
Right.
And the reason is that I have many vestibular patients who've got bilateral loss and normal hearing who tell me, look, if you can improve my balance, I'd be happy to lose it. But the problem is we're not able to demonstrate yet that we can chronically improve their balance. Until we have a device that we know will provide improved balance for many years, I just can't see putting the hearing in an ear at risk.
Okay. So
We need a lot more confidence.
One more question was there. How does vestibular implant get stimulated in real time?
So that depends on what kind of context you're talking about. So we use a variety of different types of stimulation. So we will look at the effects of just fixed unmodulated pulse trains. We look at the effects of modulated pulse trains using, say, sinusoidal modulation. And then we look at the effects of rotational modulation. So in subject number 2, where we restored her normal VOR, she had a rotational sensor attached to her head, which was sensing her head rotation and modulating the amplitude of the pulse train with her head rotation. Now, some of you who know a lot about the vestibular system will say, wait a minute, the normal vestibular system doesn't modulate amplitude, it modulates frequency. We've studied that, as has the Hopkins team, and amplitude modulation with electrical stimulation seems to be a more effective stimulus than frequency modulation is. We don't really know why that is yet, but so far we've used amplitude modulation. From a practical standpoint, we're reprogramming a cochlear implant to do this, and while it's possible to reprogram a cochlear implant to do frequency modulation, it's much easier to reprogram it to do the amplitude modulation, because that's what it's programmed to do in the first place. But so far, in both monkeys and humans, amplitude modulation appears to be a more effective electrical stimulus than the normal or natural frequency modulation, which is somewhat surprising to us.
Okay. Again, Dr. Ramesh Rohiwal is there asking about the role of balance belts in patients with bilateral vestibulopathy. Do you know something about balance belts?
I'm not sure I understand the question.
The role of balance belts in bilateral vestibulopathy.
I don't know the relationship between the balance belt and the vestibular implant that the question is addressing.
Okay.
Yeah.
So I think Dr. Srinivas would like to ask something.
I'll be in my room.
You have to unmute.
Yeah, let me unmute him. Yeah.
Right now I'm going for a bath. I go to
A lot of noise coming from somebody's phone.
Mohan boss.
Somebody's
I go to my room.
You have to mute yourself.
Sir, you can mute everybody and unmute.
Yeah.
I have a couple of observations. Okay, so it was a very honest presentation and an open presentation. In the sense, you actually showed us the surgical placement of the implants, which was very good for us, and you are very honest in sharing the initial experiences, not being very euphoric about the results. Okay, which is very, very important to place things in perspective for a lot of us, and also the damage that it does to the residual hearing, unless there is a cochlear concurrent indication to actually do a cochlear implant as well, not to do. So they are all very impressive points, and which we need to note. And there are two things about in your presentation which was very beautiful. One thing was, when you are doing the stimulation of one particular canal, there was a movement in another plane. Like maybe when you said the horizontal canal, there was a vertical movement, and also in the posterior canal you also observed a horizontal movement. So all these days, this kind of an experiment was in humans was only possible through an experiment of nature, which is benign paroxysmal positional vertigo, where a single canal used to be stimulated. And we used to wonder why sometimes we expect horizontal canal, we only expect a horizontal nystagmus, but then we used to see a certain amount of vertical component to that. Okay, some kind of a downbeat trajectory we used to see. And even in known posterior canal benign paroxysmal positional vertigos who actually respond, we used to sometimes see some amount of horizontal trajectory to that. So that was an experiment of nature. Now to the experiment of nature, you have added an experiment of actual electrode in that, and that also is showing the same kind of pattern. So we can't extrapolate what we saw in the animals and what we saw in the pigeons to human beings. Probably in the human being, the trajectories, the muscle supply of the semicircular canals is a little different. The other point that you made was about the facilitation of cochlear implant, cochlear stimulation and the vestibular stimulation, mutual facilitation. So we do know that in anatomical studies that there are a lot of anastomosis between the vestibular and the cochlear, right at the peripheral level onwards and then into the center. So maybe we don't know what those all the role of those anastomosis is not as of now determined or known. Maybe one of the role is to facilitate one another's response, and what behavioral advantage that kind of a facilitation has. It's a matter of speculation. But then when you come to the balance performance in people who are bilaterally cochlear implanted, who say that their balance is a little better, even bilaterally hearing aids people who are given, who subjectively report that their balance performance is a little better after bilateral amplification. So maybe cochlea is not just about hearing. Cochlea is also some kind of a facilitatory role in the vestibular. And for your findings, okay, is opening up a lot of thought processes, and I'm very thankful for that.
Yeah, thank you. The suggestion that the vestibular cochlear anastomosis may be contributing to that effect is a really good one. I hadn't thought about that, and nobody else on our team did either. And if you read our paper in audiology and neurotology, we don't raise that as one of the possible causes. But it makes a lot of sense that it could be, because, as I mentioned, if you stimulate the vestibular system, they don't hear it. If you stimulate the cochlea, they don't get rotation or sense or eye movements. But if you stimulate the two together, they interact with each other. That implies some sort of suprathreshold phenomena, and a neural anastomosis would account for that much better than current spread within the within the inner ear would. So it's a fascinating suggestion. So thank you very much for that.
And one more point. If at all you are thinking of a multi-center study for the vestibular cochlear implants at some point of time, India presently has more than 500 vestibular evaluation labs with a lot of professionals who are doing beautiful evaluation when it comes to eye movement, electrical stimulation, that kind of thing. Highly trained professionals who are doing that kind of work. I just wanted to keep you informed that that kind of a facility is available in India. Sometime in the future, if you're thinking of multi-center trials or something, you can look at India.
Yeah, we can do it together.
Absolutely. When we are at the point where we feel, so we're now at the point where we know our second generation implant provides robust stimulation for well over a year. We now need to be certain that we can have an external device that's easy to use and easy to program, and can and can be used as part of a clinical trial. Once we have that, then we'd absolutely be ready for a multi-center clinical trial. I've only, unfortunately, been to India once, but I would leap at the opportunity to collaborate there.
Certainly. One personal question, rather, I wanted to ask. It's like an interesting one. What motivated you? What impulse or what that moment motivated you to switch over from engineering field towards the medical field? Because initially you started with the engineering career, then you became a doctor.
Yeah, so I come from a family of engineers.
Okay.
My brother is actually a very famous engineer. His name is John, Jon, for anybody who wants to look him up. I became very interested in hearing as a result of my musical training.
Okay.
I've been involved with music since I was 5 years old. And the first engineering project I began working on was in looking at automated speech recognition. And I became very interested in how people understand speech. And at the time, there was some very early work by a neurologist at Harvard looking at the effects of different types of strokes on language perception. And I thought that was just really interesting, and decided that I wanted to go to medical school and figure out how the brain worked. And en route to medical school, I encountered some of the first research from the cochlear implant research group at Stanford, and realized that that was really what I wanted to do. And it took a number of years in medical school before I figured out that as a neurologist, I couldn't do that. I needed to be an ENT. So that was the progression.
Oh, great.
Pawan, I have a technical question. Can I ask?
Yeah, certainly, sir.
Jay, I wholeheartedly congratulate you for that wonderful work of yours. I have a technical question. I am a technical man from medical field. I am slowly getting into engineering and technical fields, other way around. So what I wanted to know was whether you're exploiting the same speech processing strategy to stimulate the vestibule, the ampullars, or you developed a separate software like vestibular stimulating strategy or something?
Yeah, great question. So currently what we're doing, again, because we have to write all of our own software for this, cochlear doesn't help us write our software. We do the simplest things possible. So we take, I told you that the output of our velocity sensor is amplitude modulated on an audio frequency. We then program the cochlear implant speech processor to extract that amplitude modulation and stimulate a single electrode. So there's really no fancy signal processing on top of that. My first paper in the vestibular field was written many years ago, and in fact, Charlie Della Santina is my co-author, where I postulated a variety of signal processing strategies that one might use for a vestibular implant. That was before anybody had done human vestibular implants. We've not gotten to the point where we've been able to try any of that yet, because we're still at a very early stage. But those would be the sorts of things that once we had a device that provided regular clinical benefit that could be studied in clinical trials, then that would be the time when we begin to look at alternative signal processing strategies.
Yeah, but I see that unlike cochlear implant, where it converts, the speech, this thing into electrical stimulation, here you're taking from accelerator into speech and then into a electrical stimulation, right? A two-way conversion.
Correct, and we do that to make it as simple as possible, given that we don't have a dedicated vestibular processor. We're reprogramming a cochlear speech processor to become a vestibular processor, and that was the easiest way to do it.
Yeah, that's a great feat, really. I congratulate you for that work. Yeah.
And the best part of it is it doesn't interfere with the cochlear implant part of it. So a speech processor could do what we're doing and also implement a cochlear implant speech processing strategy at the same time without impacting the hearing performance of the speech processor.
Okay. See, this receiver stimulator unit, it has a separate power source for vestibular stimulation, or it is using the same power source?
So the stimulation uses the normal cochlear implant power source, but the velocity sensor currently has a separate power supply.
Okay. But see, the cochlear receiver stimulator unit, it has only one power supply. So how do you exploit that?
So the receiver stimulator is powered by the speech processor.
Yeah, that's right.
And so the implant is powered by the speech processor.
Yeah, that's right.
But our external velocity sensor has its own separate power supply.
Okay.
And that's what the patients were wearing in the little knapsack.
Okay.
They were wearing the power supply for the velocity sensor, but the speech processor powers the implant. And the speech processor is what we're using to process the output of the velocity sensor.
Okay, no. What the technical confusion I had was, see now, suppose if you're stimulating cochlea and this vestibular at the same time,
Yeah.
The receiver stimulator unit of this cochlea has only one power supply.
Correct.
So, yeah, how you are going to sequence your stimulating signals? That's what I was worried. Yeah.
You know, if you think about it, the way it's set up is the vestibular implant is electrodes 1 through 6.
Yeah, that's right.
The cochlear implant is electrodes 7 to 22.
Yeah.
And it's all powered by the same.
Device. Yeah, that was my concern. Yeah.
Okay.
Good evening.
We do have one more question by Dr. Kshitiz Malik, who is treasurer to Society of Neurotology India. Kshitiz, you can ask your question.
Hi. Yes, can you hear me?
Yeah.
So my query to you is that I understand that there's going to be a significant time frame delay before these implants are commercially available. Till that time, how are you managing your patients with bilateral vestibulopathy? What sort of balance retraining are you offering them?
Yeah, great question. So I have a lot of patients with bilateral vestibular loss and normal hearing who clearly are not a candidate for any of these early studies. And I live in a community that thankfully has a large number of very, very good physical therapists. And so all of these patients, even years later, are still seeing the same physical therapist. You know, maybe not once a week like when they started, but periodically. And that in my practice, that's been the most important thing to sort of maintain good health or good vestibular health among my vestibular patients with bilateral loss or even uncompensated unilateral loss, is that I tell them, you know, never stop doing vestibular rehab. You know, I tore my anterior cruciate ligament skiing, and my balance is not nearly as good as it was before I did that. I actually went and saw a vestibular therapist myself and do ongoing balance exercises in my daily routine to try and preserve my own balance. And I don't have any vestibular dysfunction. So I think that's probably ongoing connection to someone who's trying to help them with their balance is probably the best we can do at this point.
And you mentioned vestibular therapists. Are they different from physiotherapists, or are they more trained physios? What sort of exercises are you? Is Cotton Cooksey still a part of the lingo, or it's sort of you've moved on beyond that?
So in the United States, vestibular rehabilitation is a subspecialty of physical therapy. And so we have a number of physical therapists in our community who only do vestibular therapy. They've received specialty training in that, and that's all they do in their practice. And unfortunately, I commonly see patients from very sparsely populated regions of my state and from Alaska and Idaho. These are very, very minimally populated states, and they don't have access to a balance therapist or a vestibular rehabilitation therapist. And I can see the difference in their outcomes. You know, you talked about somebody spoke about doing a natural experiment. This is sort of a natural experiment. We have people who don't have access to appropriate physical therapy and people who do, and the differences in outcomes are pretty dramatic. But having said that, the day we actually have a safe vestibular implant that we can provide to large numbers of people, even the people with the best outcomes, I think, would leap at the opportunity.
Okay. So I think we have reached to the time limit for the webinar. It was nice interacting with you. There are still a lot of questions left. People are asking on my WhatsApp. I think I could forward that with you, Jay, sometimes in your mail, and we can share that with our attendees. With a young blood who is like so enthusiastic learning vestibulopathies and their rehabilitation and all these new things. You are gonna You have enlightened us with that. Amit Kesri is there or not there? So Dr. Amit Kesri is our secretary for the association. I think Amit, you can conclude the session by thanking Jay
Yeah.
for
Yeah,
his
one more.
Yeah.
Pawan, do we
Yeah.
have permission to post the video on the NES website and
Yeah.
NES YouTube channel?
So
Jay,
Jay, can we use this recording to post on our YouTube channel of Neurotology Society of India?
Sure.
Can we do that?
Yes, the data is all published, so that's fine.
Oh,
oh,
thank you
great.
so much. So
Yeah.
Amit, you can conclude the session by thanking him.
Dr. J, on the behalf of the Neurological Society of India, I would like to congratulate you and thank you very much for giving us time. It was a very lucid presentation and we enjoyed the concept and the limitations and how you are overcoming it. And maybe that in years to come, we would call you for in-person appearance in a Neurological Society meeting of India. So hope to see you soon. Take care and
I
have a
hope
nice.
we'll get to meet in person. Thank you very much.
Yeah.
Thank you so much, Jay. Thank you for getting us this important info and time. Thank you all. Good night. So the next session would be going on 7th of July. And Dr. Prem Sagar, Associate Professor, All India Institute Medical Sciences from New Delhi, would be speaking on migraine-related vertigo. And Dr. Pradeep Punduwali would be moderating that session. Thank you so much. Good night, all.
Yeah, yeah.
And you can message me on my WhatsApp number. I've already told you. Any query you do have, anything you want to ask. Good night.
Thank you, Dr. Plas, sir.
Yeah,
Again.
thank you. Good night, all.
Good day, Jay.
Thank you, Jay.
Good day, Jay.
Yeah, yeah.
It's a good day for you.
Take care of yourself. Yeah.
Bye.
Bye-bye.